Listen now as Carl Pepine and Dr. Emile Mohler from the University of Pennsylvania in Philadelphia discuss claudication treatment comparative effectiveness, 6-month outcomes from the CLEVER study.
Emile, explain that acronym to us.
Well, Carl, the CLEVER study stands for Claudication Exercise versus Endoluminal Revascularization and was a prospective study supported by the NIH.
And tell us why you did this trial, Emile.
The trial was initiated because there has been relatively little data comparing exercise rehab, which of course is recommended in patients with PAD and stable disease, versus an iliac stenting approach. And we chose the iliac area because of more proximal lesion and, again, very little data comparing these head-to-head.
And what treatments did you use in the CLEVER trial?
Patients were randomized to 3 different groups. The first was an optimal medical care group, which involved background care in risk factor modification as well as cilostazol. And by the way, all patients in the study received cilostazol as background therapy. Then patients were also randomized to exercise rehabilitation or an iliac stent approach.
Emile, there's a feeling in our practice area that all of these patients should receive clopidogrel. Did you have any specific recommendations for that in the trial?
All patients were encouraged to be on an antiplatelet agent, but the specifics were left up to the referring physician.
Okay. And how did you define compliance with these 3 treatments?
Optimal medical care involved being seen by the research coordinator and the principal investigator and encouraging to modify risk factors and take their Platel, and that was done by a pill count for compliance. The exercise rehabilitation group, patients were seen 3 times a week and supervised in their exercise program. And we defined compliance with that, having more than 70% of their visits attended and going through rehab. And it turns out, actually, in that rehab group, that more than 70% of patients actually completed that compliance. We were very pleased with the compliance of patients in rehab.
Emile, what was the primary outcome measure?
The primary outcome measure was pain-free walking time at 6 months on a graded treadmill study.
And wanted to just summarize the results.
The main results, again, at 6 months indicate that patients who underwent exercise rehab or underwent iliac stenting both had improvement in peak walking time compared to the control group. Interestingly, if you delve a little further and compare the stenting group versus the rehab group statistically had somewhat of an improvement compared to the stent group.
And what about quality of life measures? Were they part of the outcome?
Yes, absolutely. Quality of life was tested as well, and we found that, again, the rehab group and the stent group both had improvement in quality of life. And opposite of what happened with the peak walking time, actually patients with quality of life had somewhat improvement with the stenting group compared to the group who received exercise rehab.
Did these results surprise you?
Well, I wasn't surprised that patients improve with exercise rehab. That's been shown before, but it did surprise me somewhat that exercise rehab beat out iliac stenting at the 6-month time point. The study is being continued for 18 months, and it will be interesting to see what the long-term data show. But I think it just goes to show you that patients do have valuable options now. They can either undergo stenting or rehab and expect improvement if they adhere to a rehab program.
Emile, how much rehab was contained in the stented group? In other words, should we view this as stenting plus exercise compared with exercise alone?
No, I don't think we should review it that way. The group that received iliac stenting did not undergo a supervised exercise program. They, of course, were encouraged to walk as much as they want at home and do whatever they feel as far as their lifestyle would handle at home, but they didn't go through a supervised program. So we see, I think, from this that a supervised program could be additive. And I think what you might be bringing up is, could you actually tailor both therapies together? And that would certainly be an option.
Can you tell us the implications of CLEVER for our patients?
I think now they have 2 viable options. Again, they can either undergo an exercise program and see what benefit they have, or undergo iliac stenting. Both, you can tell patients, will improve their walking ability and their quality of life. And I think now, given these data, I think it's important for us to present these options to patients. But also, I think it's important for us as physicians to help the patients undergo the appropriate care that they need.
I'm really intrigued by the quality of life results. Do you want to go into those a little bit more? What were the measures that you used?
So we used a free walking pedometer, accelerometer measure, walking measure, as well as walking impairment questionnaire and other questionnaires that explore the patient's improvement in quality of life. The patients, again, both in the exercise group and the stent group had improvements in these quality of life measures, but the stent group seemed to gain a quality of life with questionnaires and even an accelerometer more than the group that received supervised exercise program.
Emile, now that you have these results, can you speculate on the mechanisms?
That's a good question. We didn't really look into the mechanisms here. This is really a comparative effectiveness approach with the assumption of equipoise between the two groups. But now that we do have some subtle differences, I think we can explore why you might have an immediate quality of life improvement in patients with stenting versus a farther walking period with rehab. And you could obviously speculate that maybe patients got immediate gratification with the stenting but had to work harder eventually to get improvement with the rehab group. But how that is determined as far as a molecular mechanism or whether improved angiogenesis in the legs or performance measures in skeletal muscle myocardial performance, really we don't know from this study. But I think it does raise a lot of interesting questions like studies do where you find interesting results about how that mechanism may occur.
Were there any baseline characteristics that allowed prediction of which patient subgroups might respond better to which treatment?
So we did look at that, and I'm glad to say that of all the major measures that we looked at, from cardiovascular risk factors to medications and lipid profiles, that they were all evenly matched among the group, except for one marginal area, and that was stroke. In the rehab group, there was more patients with that particular issue.
What you're telling me is I do not have a specific set of characteristics that allows me to put patients into one of those two treatment groups that showed benefit, either the stented group or the exercise.
That's correct. There was not any baseline characteristics that would predict which group may improve.
What did HDL do in the trial?
So HDL was found to be elevated in the exercise group, which is encouraging because there have been reports in the past that exercise increases HDL. The mechanism of that, of course, we don't know from this study.
And so you mentioned to me that you're following these patients now for an additional year?
The final outcome will be at 18 months.
Is the study large enough that we can expect some trends in clinical outcome?
The study wasn't powered to look at clinical outcome or cardiovascular events, and we're happy to say that there were no significant cardiovascular events in the population at the 6-month endpoint.
Very good. Emile, thank you very much. You've summarized a very important trial for the patients that we see who have claudication, and I think our listeners will gain some perspective on how to treat these patients in the future.
Thank you very much.